If you said B, cholesterol emboli syndrome, you are correct. Cholesterol emboli syndrome is a complication of PCI, during which atherosclerotic debris embolizes. These emboli can go to the toes, fingers, where they can cause ulcerations or pain. They can also cause livedo reticularis of the skin. Emboli can also travel to other organs like the kidneys and liver and potentially the brain, causing strokes. Some other complications of acute MI are also important to remember and are typically caused by infarction of myocardial tissue. Papillary muscle rupture can cause acute mitral regurgitation symptoms leading to acute heart failure. It's treated with vasodilators and surgical correction. A ventricular septal defect can form if there is infarction of the ventricular septum. This is characterized by a systolic murmur that does not radiate to the axilla. Left ventricular free wall rupture can occur if the infarction of the myocardium causes so much weakness that the wall ruptures on its own. This typically presents with cardiac tamponade, which can be identified by pulsus paradoxus, elevated jugular venous pressure, and diminished heart sounds, and often causes hypotension. These patients need urgent pericardiocentesis and surgery. A left ventricular aneurysm can also occur because of weakened left ventricular myocardium, but this typically happens weeks later from cardiac remodeling. This can present as with heart failure symptoms, and EKG will often show persistent ST elevations. Pericarditis can occur after myocardial infarction as well. It can present very early in the course with continued chest pain. On EKG, you will see diffuse ST elevation and PR depression. It's managed with aspirin, but NSAIDs should be avoided at this point. It can also present later, anywhere from 1 to 8 weeks after the MI, with the same EKG findings and occasionally fevers. It can also be treated with aspirin, but at this point it's safer to give NSAIDs or steroids to manage the symptoms. When you see an ST elevation on EKG, your differential diagnosis should include more than just a type 1 MI or a STEMI. Principal angina can present exactly like a STEMI and has the same need for initial workup. Pericarditis will have diffuse ST elevation and PR depression across all leads, which is not consistent with a STEMI, as those are localized to the area of coronary artery thrombosis. Left ventricular aneurysm will also have ST elevations and present anywhere from 1 to 8 weeks after an acute MI, with an average of around 6 weeks. Takotsubo cardiomyopathy will also present with ST elevations, but this is a non-ischemic stress cardiomyopathy caused by massive catecholamine release, and also typically presents with apical akinesis. Let's go to our last question.